Hello, and welcome to the Things I Want My Daughters to Know podcast, the podcast redefining women's health, one unfiltered conversation at a time. I'm your host, Jacqueline Rose, and every week I'll sit down with leading women's health experts and real women to share their lived experiences, bust health myths, challenge outdated and uninformed narratives, and explore what's really possible for women. We'll talk about periods, fertility, menopause, hormones, aging, and everything in between. This podcast is for every woman who ever felt confused, dismissed, or left out of the conversation about her own health. It is a space to celebrate women, break the silence, and open up conversations between mothers, daughters, sisters, and friends. Please hit the follow or subscribe button so you don't miss an episode, and share this podcast with your daughters, family, and friends. Let's get on with the episode. Hello, everyone, and welcome to another episode of the Things I Want My Daughters to Know podcast. And today I am truly honored to have a very special guest who has been in the menopause women's health space for an exceptionally long time. And she's really going to share so much of how she has seen things change, progress, how she understands this space. This is Dr. Heather Currie. Welcome, Heather. I am so honored to have you with us. You really have held some of the most important positions in the women's health menopause space. So tell us who you are, what you do, and we'll get straight into the conversation.
Well, first of all, thank you very much for the kind words and for the invitation to join you on the podcast. I love talking about menopause and all things connected, so I'm delighted to be here. So my name's Heather. I'm a gynecologist based in Dumfries and Galloway, southwest Scotland. I have been providing care and education in the menopause world since 1993, so quite a long time. I'm a trustee of the British Menopause Society, the national authority in the UK for education for healthcare professionals. I'm a past chair of the British Menopause Society, and I am the founder and MD of Menopause Matters.
Yeah. So you are exceptionally well placed to really give us a bit of a historical perspective. And I guess one of the things that sort of to start the conversation rolling is, as I sort of mentioned to you before we hit record, is one of the missions and aims of this podcast is the information that we've had to fight for, my generation, you know, the women in their 50s, where we think now that menopause is a brand new concept. It wasn't around, 5, 10 years ago, that we've had to sort of fight to understand what's going on in our bodies. And now, I feel that in the UK, there's, a menopause coach on every corner, never existed before. Menopause in the workplace, all these things. How do you see this? Because as you said, you've been in this a long time. You were the chair of the British Menopause Society. Is that perception correct, that this is a new topic that's just sort of come into our consciousness, or is there something else that's actually been going on behind the scenes?
Yeah, this is a fascinating point you raised there. So first of all, it's absolutely not a new topic. So the menopause period stopping because our ovaries stop working because they run out of egg cells has been known about for many, 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 many years. And the whole idea of treating this, so the whole concept is, as mentioned, we run out of egg cells, therefore our ovaries can't produce the normal hormonal cycle. And the actual word menopause means the final period. So it's one day in the transition from having normally function ovaries to them going a bit wonky, which is that perimenopause where it all goes a bit up and down and crazy, to the point where we produce so little estrogen, the key hormone, that our periods stop because the lining of the womb can no longer be stimulated on a monthly cycle. And so that concept has been known about a long time. And the concept of replacing that estrogen, that all-important hormone, with hormone therapy, hormone replacement therapy, menopausal hormone therapy, MHT or HRT, whichever you want to refer to it as, that's been known about a long time as well. And a lot of research and a lot of use of HRT was actually in the 1980s and the 1990s. And when I first got involved with menopause care, providing care and education in the early 1990s, there was a huge investment and interest in menopause. lots and lots of women were taking hormone replacement therapy. And a lot of the studies that we still refer to when we think about benefits of HRT, and also risks, there are risks, but there are a lot of benefits. A lot of the research that we use to justify that idea of why we give it, how we give it, was actually done way back in the 80s and the 90s.
Right,
And
when it was so popular.
so it's been around a long time. Obviously, we didn't have as many ways of accessing information then. We didn't have social media, for example. And to be fair, there was a stigma associated. So those of us involved in the research, in the publications, were talking about it all the time. There was
All the
loads.
time.
And actually, my company, Menopause Matters Limited, was set up in 2001, so over 20 years ago.
Just at that time as the
Exactly.
WHI research was coming
Exactly.
on.
And the reason I set up the company, because although there was a lot going on, there was lots of meetings, lots of talk, there was a lot of confusion even then. It got even worse in the early 2000s. And I wanted to provide information in a accurate information, resources that women could access, because the whole point of what women do about their menopause transition, their menopause, post-menopause, is about them making informed decisions. And so
Yes.
what I wanted to do, and this has been the concept ever since, is that we give information so that women can make their own choice, but it has to be accurate information. So loads was going on in the 1980s, early 90s, and in the 1990s in particular. We actually had more types of HRT than we have now. There was new developments, new
Interesting.
things happening. And why I converted a little information leaflet into a website is because the leaflet was regularly out of date because so much new stuff was happening. And so in the early 2000s, we had increased use of the internet and websites appearing. And that's why I did it as a website, so that we could easily update it. So what then changed in the early 2000s was we had a publication with huge publicity of the Women's Health Initiative trial from America, and also the Million Women study from the UK. And both these studies, the publicity around them emphasized the risks of HRT rather than balancing benefits against the risks. And almost overnight, there was a huge change in the number of people using and prescribing HRT, a massive drop, and also a loss of interest and less research going on. Those of us already involved in it were then really worked really hard for all these years to try and get back the momentum, because even when these studies came out, we could tell that actually this is wrong. This is not the right message. Everything has a risk, but let's not emphasize the risk. Let's not forget the benefits. For most women who choose to take HRT or MHT, the benefits outweigh the risks, and that message had been lost. And so that's why a huge amount of work was done to get back the interest, to get back the investment. And so in that time, though, also, as I mentioned earlier, there was some stigma. It was still a word that wasn't used much. It was that, oh, it's that time of life, or I'm at that age kind of thing. And examples of that, so just coming on a few years, Menopause Matters website, loads of visitors, loads of information there. And then in 2005, I thought, let's bring out a magazine. Let's try and get information, because although increasing use of the internet, there was still a lot of us, including me, that like to sit down with a magazine and a cup of tea. And the other reason for doing it, so it's to reach a different audience, to give different types of information, to give personal stories, which I felt worked nicely in a magazine, but not necessarily scrolling down on a web page, but also to glam it up. Because of this stigma, I wanted glossy magazine. I wanted great pictures. I want positive stories. And so we brought that out in 2005. A few years later, when I wanted to get it into shops so people could go into shop and pick up Menopause Matters magazine, the company I worked with to place it into shops said to me, yes, that's a great idea. We can do it for you, but you'll have to change the name. And I said, Why would I want to change the name? Menopause Matters. That's a great name. It's the
Yes.
same.
It says what it's, yeah, it says what it is on the tin, as they say.
And their reply was, no one will want to be seen going into a shop picking up a
Yeah,
magazine with the word menopause on it. And
menopause.
my answer was, and that is why I'm not changing the name, because that
Yeah,
just reinforces this is a word that shouldn't be talked about.
yeah,
And now it's gone completely okay
yeah.
to talk about menopause. People are looking for information. So that's a very long answer to your first question as to what's happened.
No, I think it's a really important perspective. And I guess leading on from that to where we are today in 2025, almost 2026, how do you see, and this may be a bit of a challenging question, the pros and the cons of where we are today? Because I think it is amazing, but I do think there are some downsides or some nuances that have been missed in the explosion of the menopause conversation. So maybe I want to challenge you a little bit to ask you, in today's world where menopause now is not a dirty word anymore, in most places, where do you see the pros and cons of the historical development of where we are?
Yeah. So it is good that it's an easy word to say now, that more people are aware of it. It's good that there's a recognition of the impact in the workplace, that people are finding going to be able to more and more find support in the workplace. You know, people have been often, I think, in the past worried about talking about how they're feeling because they don't want the line manager to think they can't do the job. But it's
Yeah,
becoming much more open
yeah,
and talking about it in homes. So all that is great. What is not good is the industry that's developed around it, and that there are so many options now for women to, for example, there are kits they can buy to get their blood levels
yeah,
measured
their
for
hormone
hormone levels.
levels.
And there are times when they're told that we can measure your hormone levels and titrate your hormone therapy against your hormone levels, and this is bonkers. I mean, there's no scientific logic to that. That we go by clinical symptoms, we go by pattern appears, we don't need blood tests. With someone is choosing to take hormone therapy, we go by how they're feeling. What are the symptoms under control? What are the side effects? You don't need to be adjusting it minutely because our own body produces it in a very up and down way. We just need to keep it safe. So there's the safety aspect and there's the misinformation aspect. So the also, you mentioned there's a menopause coach in every corner. So yeah, people are doing a great job supporting people and giving them the right information, but there's a lot of misinformation.
Yeah,
And what's happening now, which is really quite worrying, is that people will. I remember here we did a great podcast from my own series of podcasts, Menopause Matters, Let's Talk, with Sue Davis, who's a professor from Australia, who's absolutely one of the world experts on hormones and has done lots of research. And she pointed out that if you really believe something, so if you hear someone on social media or someone on the telly that says, this is what worked for me and this is what others should do, first of all, do not tell other people what to do. The menopause experience and their need, requirements, or response to hormone therapy is completely unique, completely individual. So
yeah,
someone might click on something, and then if you have an idea in your head, this is the correct thing, you can find a research paper that will justify your belief.
yeah,
But the papers show very, very differing results. And what we really have to trust is the organizations that put all the information together. So there's such a range in the people in studies that have been researched, in the duration of treatments, in what they're looking for, in the statistics used. There is so much research that you should never just focus on a paper or a message that someone has given about one thing. It has to be put all together. And that's where we have to really trust the NICE guidelines in the UK around the British Menopause Society that I'm a trustee of, the consensus statements, the review analyses, putting all the papers together, which may not be what links with what you want it to believe, but that's what we
yeah,
have to trust. And we're in a situation now where we have people criticizing the researchers, criticizing organizations that produce these guidelines and documents because it doesn't fit with what they want it to hear.
To say. You're touching on such an important point because I think that the research and the this phrase evidence-based research or evidence-based information that is really being touted in the menopause space can be really confusing because, as you've said, you're always going to find research to support your line of thinking, but it's not just about one research paper. And I think a lot of the research done, and please correct me if I'm wrong, there are a lot of research out there on menopausal women and the impacts of HRT, but the women that they have been tested on are women who've either gone through hysterectomies or ovarian removal and hysterectomy and uterus removal. And that's not necessarily a good sample base for the average woman to be basing her, her practice on. But that is, again, I'm not enough involved in the research. I do know though that a lot of the papers that are being used as evidence for are based on, as you said, a range of different women's samples that may not reflect your personal experience. And thank you for saying that every single woman's experience is unique to her. So given this, what do women really do? Because there is so much noise on social media. There are so many big menopause influencers now claiming all different types of things. And the biggest noise gets the biggest reaction, but the regular woman is still suffering and struggling and doesn't know who to believe, what to listen to, documentaries on television. It's really confusing. And for me, that's one of the big cons of the rise in the menopause conversation. There's not only misinformation, but so much information.
Yeah. And actually, when you say people of your generation have had to fight to get information, I think you haven't had to fight to get it. You've had to fight to get the right information because there's so much confusion. And if I wasn't involved in all this, I would think, well, how on earth do I know who to believe? Who can I trust?
Yeah.
Because they come over, a lot of people come over as really credible. So the key thing is, yes, look at different information, but remember, you are not going to respond in the same way to someone else. And, if someone does, first of all, not everyone needs HRT. That's another misinformation, that actually HRT is fantastic, it's wonderful, and it's safe. And there are newer types that don't have risks associated with older types, and everyone should take it because it's good for your symptoms, it's good for your bones, it's good for your heart, it's good for your brain. Not exactly right. And if you think about it, everything we do has a risk. So if we take aspirin, that has a risk. So we have to.
I just want to challenge you on that, because that is now the narrative coming out from the UK, that you should be taking HRT not only for symptom treatment, but for long-term bones, brain, heart health, for healthy aging. Now FDA has removed the black box warning. HRT is wonderful and safe unless you're in a particular risk category. And we don't just want to take it for symptoms, we want to take it forever. And women are believing that, because why shouldn't they? Because some very credible experts are. And that is now the narrative that is very, very popular in the UK and spreading to America.
Yeah. So basically, there are 3 indications for the use of HRT, and these indications have not changed over many years. So number 1, and the most common, most likely reason that someone will choose to take it, is for control of menopausal symptoms, which are related to them having become low in estrogen. So it kind of makes sense that if we replace the estrogen, then yeah, that will help, because there's estrogen receptors throughout the body, and the lack of estrogen can trigger changes. However, it cannot just be about estrogen, because if it was, every woman would be affected in the same way. It's the same biological process. The perimenopause bit, when it goes a bit wonky, and the age at which it happens varies, but the actual end process of becoming low in estrogen is the same for every woman who outlives the time that her ovaries are going to be working normally. And so if it was just about estrogen, we'd all have the same response. But
You'd
we know that,
see you'd see cookie cutter experiences of each woman.
yes, but we know that there's an enormous variation, as to whether someone has symptoms or not, if they have symptoms, what symptoms they are, what the severity of them is, what the duration of them is. None of these can be predicted, by the way.
Yeah.
It's a kind of wait and see. And also, the key thing, even if two people did have the same symptoms, the impact would be different because their lives are different. Because it happens also when there's so many other life stresses and there's so many other factors involved. And what we just don't know what is going on in these receptors throughout our body. There's so many other factors that influence that. And therefore, the requirements or not for treatment for symptom control are completely unique and individual. So when I talk about contributory factors, it's related to stresses and what stress hormones we're producing, which interact. What about nutrition? And there's a big focus on the microbiomes in our bowel and how that's affected by estrogen, but all the other things we subject our bowel to. What about alcohol? What about caffeine? What about exercise? What about lifestyle? There's just so much involved. But the remaining main indication would be for symptom control that are having an impact. And we do know, so while we do know that some people can have quite severe symptoms that can affect their life, and treating them can transform their life, fantastic. However, we know that some women don't have any symptoms at all. So so part of that is to say, the theme of this is, what do I want my daughter to know? What do I want my daughter-in-law and my granddaughter to know? Is around, don't necessarily dread it. It doesn't mean it's going to be terrible. And what we see on social media, and linked a bit with research, research from the beginning can be biased, because what about the people who choose to go in the studies? Are they different from people who well, no, I don't need to go into that. I don't, that's not a problem. So there's bias at all levels, really. Okay, so that's the symptoms. The second indication is for the young women. So if someone has premature menopause, or the term now is premature ovarian insufficiency, POI, menopause under the age of 40, which we think probably now affects about 3% of women or so. We used to think it was 1%, but probably about 3%. We know that there are other reasons for taking hormone therapy other than symptoms, and we also know that affects women under 45 as well. So early or premature menopause, premature ovarian insufficiency, the recommendation is, whether or not they're having menopausal symptoms, even if they're not having symptoms, we would recommend replacing hormones and take that at least until the early 50s, because we know that these are the women that are more at risk of the long-term health problems. So the earlier that you lose estrogen, the more you are at risk of things that estrogen's really, really good for long-term, which is the bones, the heart, and the brain. So in those women, unless they have a hormone-dependent cancer, we would recommend taking hormones in that situation. The third group is for women who have risk factors for osteoporosis, because we know estrogen is really good for our bones at any age. And so those are the three remaining indications. If someone becomes menopausal, the normal range is 45 to 55. Menopausal at that time, without symptoms and no risk factors for bone health, there's actually you're not really necessarily going to gain any benefit from taking HRT with no particular reason, because there's so many other things we can do we've talked about the bone health. We need to be better at identifying people at risk so they can have appropriate therapy. For heart health, it's probably is the case that if we start HRT under the age of 60 or within 10 years of the menopause, it probably is beneficial. But also, there's so many other things we can do for our heart health, like our nutrition, our exercise, not smoking, for example, that actually there isn't enough, according to the NICE guideline that summarized all this, there isn't enough evidence to suggest that we should take it anyway, whether or not we have symptoms. Better would be to focus on the good other things we can do for our heart health.
The lifestyle measures.
Yeah, exactly. And related to brain health, it's not clear enough from the research that we have at the moment for people having menopause at the normal age range. It's different for the young women, but for the normal age of menopause, it's not clear enough that HRT is protective for our brain against dementia, for example, if we take it in the absence of symptoms. So the three indications that have not changed, the misinformation comes from people's wanting to cut across this belief that HRT is the answer, has lots of answers. Because behind this is, as I've said, it's not perfect. It does have risks. And the main concern around risk is a small increased risk of breast cancer, which is duration dependent. There is this idea that the newer types of HRT, I would be putting newer in inverted commas because these are not new types. We've had the types we have now, we've had for decades. It's just more emphasis on which we're using and which we're starting with. But the newer types of HRT, as they're called, we cannot say they're absolutely safe for breast. We know that breast tissue is stimulated by estrogen and progesterone, and that occurs in our cells. So we know that women who have a later menopause, so menopause after the age of 55, where they're continuing to have breast tissue exposed to hormones, we know that they have an increased risk of breast cancer compared to women who have menopause within that normal age range. So it just doesn't seem logical that any type of HRT is better than our own hormones, if you see what I mean. So there are short-term studies which suggest certain types of progestogen, which is part of the HRT, can have a lower risk than some other types of progestogen, but not with longer term. There is still that association. And the big thing is, this is a small risk, but it has to be taken into balance. It has to be in perspective, and it has to be balanced against the benefits. And for some women,
and also balanced against the other greater risks like alcohol use, for example. We know that alcohol use is a much bigger risk factor for breast cancer than HRT potentially.
Alcohol, obesity, these things are also linked, and so it is looking at other factors. Exactly. Having said that, there is no arbitrary limit as to the duration of HRT, but again, it has to be an informed choice, not based on inaccurate information. And so that we know that, some women in the 70s are still having intolerable symptoms. If they have no sort of family history, no other things increasing their individual risk of breast cancer, then they may well choose, actually, life is for living. I want to feel good. I want a good quality of life. And if HRT is the only thing that helps me do that, it's perfectly reasonable for them to be supported to take it as long as they want. But it should not be a blanket approach, which is what seems to be happening at the moment.
Hearing you say all of this, especially as someone who has so been in the field for such a long time, is very, very powerful, because it's so difficult for the regular woman to explain why it doesn't make sense to her, or why she's got to battle this narrative that is so strong out there that HRT should be taken for forever. But I want to just ask you two questions. Well, three questions, but one of them is a bit controversial. So I'll ask it, and you can plead the fifth, as they say, and decide not to answer it. The first question is, why do you think this narrative is now being so strongly propagated in the UK, especially, that HRT is the magic bullet? HRT for symptom use, for long-term health benefits, you can choose not to answer. But I think it's a question we need to ask. Why is this narrative being so strongly promoted? And now, adding on to that question, is now GLP-1s. We're seeing certain people really say you should be taking HRT with GLP-1 medication, and boom, you're going to lose weight and you're going to feel amazing, and you can take this forever, and it's a double whammy, and all's good in the world. It's not even anymore that HRT is enough. You've now got to add this another drug onto your HRT so that you're going to feel even better. Can I challenge you with that question?
Gosh, so the first one, Why is this come about, HRT? Actually, I would challenge that back a little bit. I think there is a bit of a pushback. I think there is some women that are saying, actually, I don't think I want to take HRT. And what makes me really sad if they're being criticized, say on forums, so good on you, do what you want, do what's right for you. So I think there is a bit of a pushback. I think so. Thinking about it, there was, as I said, there was huge millions of people taking HRT. I can't remember the numbers prior to the publication in the early 2000s of the studies that caused the big change. And we've spent a number of years kind of trying to get back to a reasonable level. Those of us involved in the field haven't been going out promoting HRT for any reason other than for some women, it is really, really helpful. It can be life transforming. The whole thing about bone health, we need to identify people at risk and make sure they have appropriate treatment. The number of people with osteoporotic fractures is huge. So 1 in 2 women are going to get an osteoporotic fracture in their lifetime. That is awful. So we have something that's really useful. Still, it doesn't mean everyone should take it for that reason. But that's a key focus, for example. But the I think we had a whole generation or so of women who lost out on that choice to take HRT and get the benefits because they were terrified of it, because it caused breast cancer. That was the big message. I mean, who would want to take something where the papers are saying doubles your risk of whatever, breast cancer, heart attacks, etc.? And so we have we have this, as I said, these people that have missed out, and that's really sad. And then I think some of the work now is kind of building on what's been gradually building for a while, and then suddenly it just exploded. And I think it is also to do with sort of celebrity influence. So celebrities that found, actually, this is an important topic, and this is what I'm experiencing, and I want to share this because I want people to be able to feel there are effective treatments that for many years had just been, oh, but HRT is dangerous, and if I take it, I can only take it for 5 years, and when I stop it, all my symptoms will come back anyway. These are myths that we're trying to get away from. These things aren't correct. So I think there's a mixture of things. I know I'm rambling. I'm trying to get my head around it
No, it's
because
important.
I don't know if we know that. I don't think there's a key thing. I think we had years of appropriate use of HRT, although even then we did have people that said, well, my doctor said it was a good idea to take it without really thinking why. So then the big fall, and then the build up again. What is the right balance? I have no idea. As long as people are going back to understanding the reason they're taking it, what to expect from it. And the other thing that's happening a lot is people taking sometimes higher doses than they need. So sometimes it is around, clawing back a bit and thinking it's not the magic answer. So some people will take HRT. It will control, for many people, the symptoms that are related to having become low on estrogen. But it's not an answer to poor nutrition, to lack of exercise, to all the stresses that women have. I mean, the thing, and it's our own expectations sometimes, isn't it, Cece? I'm working full time. This is, I think, the scenarios, working full time, children, lots of social pressures that you should be doing this, you should be doing that, financial pressures, all that stuff. No tablet or patch or gel is going to cure the stresses from that, which interacts with everything else. And so there is a tendency to take HRT. Well, it maybe has helped this, it hasn't helped that, let's increase the dose. And that becomes an issue because then you're more likely to have side effects, bleeding problems, etc. So basically, I think there's various factors. I mean, the whole work a lot of us have been doing is to get away from the stigma, has actually, in a way, led it to be more and more, it's wonderful, more and more acceptable. But is it that people are thinking things are menopause related when it's all the other stuff that's going on? And so, is it easier sometimes to take a prescription than to actually sit and think, what am I doing with my life?
100%, 100%. This is what I see with my clients, that it's much easier to stick a patch on and say, I'm good to go, rather than to, as you said, actually address what is going on in my life. What do I need to really be thinking about? Everyone's busy. Everyone is, torn in 10 different ways. We're all juggling all the things. Very often that sandwich generation of aging parents, teen kids, kids going off to university, all life as we live it today. And much easier to stick a patch on than to actually sit and think about, okay, how do I actually look at what these triggers are for me, what actually is happening. And when HRT has now become much more acceptable, much easier to do that than to do anything else.
Yeah, and HRT has an absolutely vital, important role, for absolutely huge benefits for many women. As I said, more benefits than risks. But let's get it in perspective. You mentioned the sandwich generation. We now have club sandwich generations, whereby we have elderly relatives living longer. We have our children and our children's children. And, I see people that are just being pulled in so many directions. And, the whole thing about lifestyle and being as healthy as possible, come on, let's be realistic. We're not going to feel motivated to make those changes, and it often is absolutely appropriate to get at least some of the symptoms under control, but then not to forget the other changes that we can all make. So there's a load of stuff going on. I think, therefore, there are many factors that have led to the current situation, of which the majority of it is good. It's just trying to focus women on what are the myths. Myth dispelling, myth busting moments are really important. Just key messages as to what is true, what is just a myth, really. But also then directing them to the absolutely trusted resources, such as the NICE guidelines, for example, and there's public information on there. The statements that have come out from the British Menopause Society, from the International Menopause Society, Menopause Matters, I have to mention, that's my baby. There's just stuff on there. The Women's Health Concern is the patient bit of the British Menopause Society. There's some brilliant fact sheets on there. And these are peer reviewed. These are all written by people who are expert specialists in the field. And that's what we should be trusting, really. Forums can be really helpful, but sometimes on forums, people are giving their opinions and saying what worked for them, which is interesting to know, but it doesn't mean that's the answer for the individual. So if someone does get to the point of thinking, I want to take a prescribed medicine, then it is sitting down with their primary care team initially, and not sort of, as we're seeing sometimes, is telling them what they want based on something they've seen on social media, because the choice of treatment depends on so many factors: the type of symptoms, their medical history, their family history, if they're taking current medications. That will all influence the appropriate type of treatment for that individual. And then the next bit of that is we're trying really hard to, in the UK, especially from the British Menopause Society, to provide education for healthcare professionals.
So that's what I wanted to ask you about.
Yeah, so women...
Because you have correctly said women should go and consult with their healthcare practitioners. Unfortunately, we know that typically and traditionally, especially over the last 20 odd years, the healthcare practitioners have not been as informed or as educated as the women that are now showing up in their surgeries. The women themselves have done a lot of the work, and they're coming to their doctors, and the doctors are like a bit clueless. So how do you see, from a professional practitioner side, things changing?
Yeah, so we have this British Menopause Society BMS vision for menopause care in the UK, and that includes women having the right information, having access to trusted information. It includes all healthcare professionals having a basic understanding, because menopause can present in many ways, and sometimes people might be seeing a surgeon about something, and there's a menopause or treatment type of angle into that. There's all sorts of connotations.
Well, I know that a lot of family doctors I'll be like, we'll say, well, I'm not a gynecologist. I'm not, a women's health specialist. I don't really need to know about menopause because I'm treating women who are coming to me with all different things. It's not my area of expertise. I don't need to be informed about that. And they really are the first line of treatment for perimenopausal women very often.
They are actually. And for an example, in Scotland, we have this online learning for any healthcare professional in Scotland can, for free, do a module on menopause. It doesn't take that long, and we're really promoting that. Then in every primary care team, we would love for someone to have a special interest. And so to get that further education, there are fantastic resources on the British Menopause Society, and there's a certificate that they can do from an online course. So there are levels of education, and we know we're not there. There's so much more to do, but we keep promoting this, and our membership of the BMS is going up and up. The people using the online resources is going up and up. So we're not just thinking that's it, work is done. There's continues to be more and more work.
And do you know that that's happening through other menopause societies in other countries? I know that here where I am in Israel, there is further education, medical training for doctors. But again, in all of these countries, UK or America, anywhere else, the doctor themselves has to choose to opt in. There's no formal requirement, as part of their medical certification or degree or medical treatment that they have to be menopause informed. They have to opt in to choose to do it.
So in the primary care teams, they have competencies that they need to reach, and so I wouldn't say that there is no need for them to do these courses, but you're right. If you have an interest, you're more likely to learn more. And that's why, we don't want every person in a primary care team to be a specialist. We need someone to have a special interest that women can be directed to. But that relies on the women recognizing what their symptoms are due to, which is why that's linked with the right information that women get as well. And they'll have, it'll be a much more productive, useful consultation if they've already got a basic understanding. But what we'd ask is they're open as to the advice that they're given. So yes, and is it happening outside the UK? I think it's not quite at the same stage in many places. But I think there's a gradual wave of more and more happening in other places as well. So I've managed to avoid the question about GLP-1.
I noticed that. I wasn't going to push you. It's really interesting because you say about the forums. I just chanced upon this morning one of the menopause groups in one of the Facebook menopause groups, and someone asked a question. What's been people's experiences with HRT and GLP-1s? And there were, 300 comments of, I'm on it and it's been life-changing, and together I've lost X amount of weight and I feel amazing. And very few women who, the forums are echo chambers for what you want to hear. Women aren't going to necessarily go on them and say, no, I had a terrible experience. So yes, do you want to talk about it? Do you want to go there? Tell me what you think.
I'll give you my thoughts a little bit. I'm not an expert on the GLP-1s. I'm not an expert in anything, actually, just someone who gets very interested in stuff. So they have been transforming for many people. I mean, this is the first time we have had treatments that can make a huge difference to people with diabetes, etc. So they have absolutely a role. The whole thing about weight loss, there's huge interactions with weight and menopausal symptoms. And so, weight loss, however it's done, can make a huge difference to some of the symptoms that otherwise you might think, well, HRT will fix this. It can help to some extent, but it's absolute. We all know the whole epidemic of obesity is just, and the health implications of that are enormous. And so anything that can help that must be good. And that's not a sort of recommendation that everyone should be going out and paying for these, because a lot of them are private prescriptions, aren't they? So expensive. But often I'm hearing that people find it's a catalyst and it helps. But, do we know about long-term consequences? I don't know. The So if someone, what we find often is someone is able to improve their nutrition without using GLP-1s and um, achieves an optimum weight, then they generally feel better. That's fantastic. They may not need HRT. I can't quite see the logic of thinking you need both. It's kind of, let's work out what your actual problems are, what you can do about it. As I said earlier, it's not an ideal world. There's so many stresses, but in an ideal world, let's focus on the nutrition. And I think probably we're not very good as health professionals, will say, giving support for that. It's easy to say, well, of course, if you could improve your nutrition, that would be fantastic.
Yeah.
But what was really good this year, and World Menopause Day, which is always the 18th of October, the International Menopause Society pick a theme. And this year it was lifestyle medicine.
Lifestyle.
There's some fantastic information and resources around that. And it isn't, it's being realistic. So there might be just little changes that someone can start to make that would make a difference. It's not expecting huge changes. So I
think that topic, the fact that the International Menopause Society chose lifestyle medicine as the topic, is very, very telling as to how they really want the conversation to go. Yes. That they want to maybe intentionally or not, they really want the conversation to look at what else is going on in a woman's story, in a woman's health story. And I think that it was exceptionally powerful that they chose that topic this year.
Yeah, and it doesn't mean this is to the exclusion of HRT. Women hugely benefit from HRT. Some women will be able to make changes and find, actually, I don't think I need it. It's trying to get away from what has become a blanket approach. It is trying to get people to feel confident to make decisions that's right for them. Yeah. So these things I would feel would be it would be great that we can find ways to support people to make small changes that then builds up momentum, rather than saying, oh yes, absolutely, it's not right to say you should all take GLP-1.
Yeah. I think everything you're saying is exceptionally important. Sensible is what really women need to hear, and unfortunately this sensible approach is being drowned out by a lot of the noise that there is in menopause, that is sort of more about attracting big hype and big numbers and big publicity. So as we begin to wrap up our conversation, I always ask my guests, this podcast is called The Things I Want My Daughters to Know. What do you want your daughters to know? And as you sort of referenced, your daughter-in-law, your granddaughters, that next generation of women, what is that one message that, if you could, shout it from the rooftops, that really the next generation of girls needs to know?
Do what's right for you. Simple. I probably wasn't enough a bigger message, but it is, don't listen to all the hype. Get the right information and work out what's right for you. Stick to your instincts, and know that there's lots of support there. Not one stage does anyone have to face on their own, whether it is, it's not just menopause. What about first period? I mean, that's a pretty traumatic time. Look for other support, talk about it, and don't go through what previous generations have gone through, which is just getting on with it, making do. Lots of help at all stages.
Yeah. Amazing. Thank you so much for joining me. This has been a really important and profound conversation, because you're really, firstly, your historical perspective, I think, is really, really important for women to know. And also the sensible approach that you are laying out here, I think is something that women are not hearing, and is really, really important. It's so simple, but it's really the essence to what women need to be hearing. So I really, really appreciate you joining me. Thank you so much. Where can people find you if they want to know more about you, more about what you do, more about Menopause Matters? Where can they find you on the internet?
We do have Menopause Matters has a presence on Instagram and Facebook and LinkedIn, and menopausematters.co.uk, and there's all the information there about the magazine as well, digital print issues, and links to the really trusted resources such as the British Menopause Society, Women's Health Concern, etc.
Amazing. Thank you so much. And thank you everyone for listening. Please reach out to Dr. Currie, to Heather, find her. As you can hear, she knows what she's talking about, which is the most important thing, I think, when you're looking for a trusted person to follow. And I look forward to seeing you at another episode of the Things I Want My Daughters to Know podcast.
Thank you for the invitation.